Hello and welcome to OffBlueMedical. Today we will discuss involuntary admission, end-of-life care, abuse, and other important topics. So to get started with involuntary admission, here patient autonomy can be suspended when they present a clear danger. So any patient you deem very dangerous, you can present them to the hospital and admit them involuntarily, even if they don't want to be admitted. So the criteria that goes with this is danger to self, such as actively suicidal, or the patient is doing severe self-harm, or danger to others, such as homicidal ideation with a plan and a target, severely disabled, such as a person unable to care for their basic needs, such as food, clothing, shelter due to mental illness, and severely decreased BMI in the case of anorexia nervosa, such as a BMI less than 16. So a classic example is going to be a patient who has active suicidal ideation and plan and doesn't want to get admitted to the hospital. The next best step in management here would be to admit them to the hospital. And another example is psychotic patients. The next best step in management here would be to administer antipsychotic medications and admit them to the hospital. So for abuse, is you need to report any child abuse. Children are less than 18 years old on the USMLE, and any elder abuse, any person over the age of 60, over the age of 65, who gets abused, such as a person younger than them, their daughter, their son, hitting them, you see bruises, then you report to elderly or adult protective services. For children, you're going to report to child protective services, even if you only suspect it and you are not certain. So you should let the appropriate agencies investigate. Elder abuse also includes financial exploitation. So if you see an adult who needs medications and says, I cannot afford the medications, and you suspect their children are exploiting them financially, taking their money, or buying the medications but not giving them the medication, then this is going to be exploitation and abuse, so you should report to adult protective services. One important point for child protective services is going to be if a child has severe injuries, you're not going to report. First, you should ensure their safety, admit them to the hospital, and treat their injuries, such as a broken bone or a very severe burn. You treat them first, and then you report to Child Protective Services. If it's not that emergent, you're going to immediately report to Child Protective Services. For intimate partner violence, reporting here is not mandatory. You have to know that reporting for intimate partner violence is not mandatory. So if a patient comes to you for a routine visit and you see a bruise on their face, you report, you suspect that their partner is hitting them, you don't go and tell adult protective services about this. So it's not mandatory. Instead, you're going to assess for safety. So I ask questions such as, do you feel safe leaving? Do you feel safe at home? See if they have a plan, an emergency backup plan, just in case things get bad at home. So you're going to provide resources, shelter information, hotlines. You're going to document injuries carefully and respect the patient's autonomy, and you should never report against their will. So if they say, I don't want to report this to the police, and you report that, then that's violating their autonomy. You should not do that. A similar topic is going to be consent to treat children. So in general, parental consent is needed to treat patients younger than 18 years of age. So if a 17 years old male presents with a mole on their skin and is asking you to remove it, then you should decline, because their parent's consent is needed for that, since it's a non-emergency condition. There are a couple of exceptions though. It's going to be treating sexually transmitted infections, prescribing contraception, pregnancy care, substance abuse help, life-threatening medical conditions or psychotic conditions. In all of these situations, minors can provide legal and informed consent. So there is a note which says reporting gonorrhea and chlamydia is mandatory. So you always report these communicable diseases to the health authorities, but you don't need to inform the parents. So if a 16 years old male presents with features suggestive of gonorrhea and then gets a positive test result, you must report this to the health authorities, but you don't need to report this to their parents. So informing parents of a positive test result is not mandatory. Contraception. Most states don't require parental notification or consent prior to the initiation of contraception. So for a teenage patient requesting an oral contraceptive, the physician should provide counseling and prescribe the medication. You should not decline, and you don't need to do a pelvic examination for this. You can just go ahead and give an oral contraceptive. Their confidentiality regarding minors. When a minor asks about confidentiality, especially around sensitive issues like sexual history, the physician must be upfront about legal limits. So most information should remain confidential only between you and between the child or the minor, unless there is a risk to the patient's safety or others. So the exceptions which must be disclosed is going to be suspected child abuse, suicide, homicide, certain reportable sexually transmitted infections, and as we said, we don't need to report this to their parents, only to the health authorities, and mental health emergencies, and in some states, abortion consent. So abortion is a very sensitive topic, and it's a controversial topic. So abortion is going to be controversial, so they don't tend to bring this up in examinations because the laws change. Some states allow this, some states don't, so it's a controversial topic. But if a woman, let's say you were in a state that allowed abortion and you were not comfortable with an abortion due to your religion or your preferences, so if a woman presented and wanted an abortion, you don't just tell her, I don't do this, and that's going to be disrespectful. So once you initiate the relationship with the patient, once you build rapport with the patient, then you should refer her to a doctor that will do the abortion. So for child abuse and legal concepts related to that is going to be child protective services. We already mentioned if there's a child who gets abused, then you're going to report to child protective services. So there's an issue, which is who gives consent for medical care if a child is removed from the parents? Is it the child? Is it a guardian? Is it their parents? So it depends on the legal agreement. It could be their parents if their rights aren't terminated, a foster parent, or a state-appointed guardian. But you don't need to worry. The question will always provide the context that you need to answer this correctly. So a question regarding consent and children and their parents is going to be a 10 years old girl who got diagnosed with acute lymphoblastic leukemia. Her parents refused chemotherapy, insisting on pursuing herbal remedies instead. The physician explains the necessity of chemotherapy for survival and encourages the family to continue the treatment while learning more about their alternative choice, and they still refuse. So the question asks, what is the most appropriate next step? Respect the parents' wishes and withhold chemotherapy, or administer chemotherapy immediately without consent, or notify child protective services and initiate a court order to proceed with chemotherapy, delaying treatment until the parents reconsider. So for this question, the correct answer is going to be C. So you're going to notify child protective services and initiate a court order to proceed with chemotherapy. So why are the other answer choices incorrect? So first off, for choice A, respect the parents' wishes and withhold chemotherapy. The child here has ALL, has acute lymphoblastic leukemia. There's a very good cure rate if we give them chemotherapy. Here, if we withhold chemotherapy, then we're going to violate the beneficence principle. So choice A is incorrect. Choice B, without consent, we don't administer chemotherapy without consent. That's wrong. For choice D, delaying treatment, well, the leukemia could spread. It could get more dangerous. So we don't just delay the treatment. And her parents, they look like they are stubborn with their choice. So I don't think they will reconsider. So that's why we rule out D. So the correct answer here is going to be C. So for parents refusing child vaccination, parents sometimes refuse immunizations for their child. So your role is going to be to understand their concerns and educate them. So in most cases, you cannot force vaccination. However, if the child is at an imminent risk of a life-threatening illness, such as for post-exposure rabies, prophylaxis, or tetanus, you may be able to get a court order for treatment. Let's talk about maternal autonomy. We mentioned this, but we will repeat it here. So, a competent pregnant person has the right to make decisions about their own body, including the right to refuse medical treatment, such as a cesarean section, even if it poses a risk to the fetus. So, you always treat neonates when they are born. You need to give them their full treatment. If they need anything, you treat them, except in futile cases, such as a 21-week-old baby. That's impossible to live because babies develop the ability to breathe around the week of 24, 25, 26 and more. So a 21-week-old baby, 21-week-born gestational baby is unlikely to live. The very extreme cases. So what's the difference between palliative care and hospice? So I made a table, so you should know the differences, and this table is going to make it clear for you. So palliative care, it improves the quality of life and relieves the suffering from a serious illness, such as a colorectal carcinoma. Hospice is comfort and quality of life when a cure is no longer possible. So palliative care can be started at any time, while hospice, the prognosis must be less than 6 months, and they love to test on this. So you should know, for hospice, the prognosis must be less than 6 months. So it has to be a very serious disease. They also love to test on the difference that palliative care, curative treatment is allowed, while hospice, curative treatment is not allowed in it. So for hospice, the model of care, it can be delivered at home, it can be delivered in an inpatient setting, it can be delivered anywhere. So who decides this? Well, the patient themselves can decide this. But also there are other factors such as the severity of symptoms, closeness to death. So a patient could first get the hospice treatment at home. When they are very close to dying, then they could get transferred to a hospital or a hospice unit, and they can die there in their own time. So, and also availability of caregivers. If they are not available to help them at home, they could be admitted to the hospital, and patient and family preferences, as we said. So for routine hospice care, most patients prefer to remain at home supported by family or friends. So they require a caregiver to help with their daily needs. So there's going to be a hospice nurse who visits weekly, more often if symptoms are poorly controlled, and they provide help with them, such as giving them a bed, oxygen, medications for pain, agitation, anxiety, nausea, dyspnea, and constipation. So hospice teams are also available 24/7 for urgent issues or emergency visits. So for inpatient hospice care, it's indicated when symptoms are severe or uncontrolled, such as dyspnea, agitation, seizures. They provide continuous nursing and IV medication access. So it's used when there is a sudden escalation of symptoms at home in the acute setting, or if the patient wishes not to die at home. So first they are at home, then they get treated at a hospital. And for a rapid decline in the hospital, the family is going to choose a comfort care such as ventilator withdrawal. There is something called respite care. This is basically a short-term transfer to an inpatient unit or a skilled facility which provides relief for caregivers a few days, and it helps reduce burnout and compassion fatigue. So death is a complicated topic, but simply put, there's two types of death. There's a cardiopulmonary death and there's a brain death. And the brain death requires these to diagnose it: apnea test and the absence of brainstem reflexes. So for apnea test, this is a test where you pre-oxygenate the patient, and you remove the ventilator, and you see a rising CO2 and no spontaneous respiratory effort. So here it says no spontaneous respiratory effort after being removed from the ventilator despite a rising PaCO2, typically more than 60 millimeters of mercury. And there's going to be an absence of brainstem reflexes, meaning no pupillary light reflex, no oculocephalic or oculovestibular reflex, so no corneal reflex, no gag reflex. And findings of a brain death, they could be confirmed by a neurosurgeon and trauma surgeon. And for the USMLE, two doctors should confirm the brain death separately. Organ donation. So when brain death is confirmed, the most appropriate person to approach the patient's family about organ donation is a representative from the organ procurement organization. So this is going to ensure there is a representative handling the discussion, reducing the risk of conflict of interest for the clinicians caring for the patient. For pain management, you should always treat pain to the fullest extent. So an example on this is going to be a patient with respiratory depression with a respiratory rate of 8 is reporting significant pain. So what are we going to do? We're going to administer opioids, even if that lowers their respiratory rate and could possibly kill them. We still administer opioids to treat their pain because it is ethically permissible to provide a medication such as high-dose opioids to relieve suffering, even if it has a foreseeable but unintended consequence of hastening death. So here intent is key. So giving opioids to kill the patient is unethical and you should not do this. But giving opioids to relieve the pain of the patient is ethically permissible, and it's ethically okay because your intention is to lift the burden of pain of the patient. So for communication and psychosocial support, there is a protocol called the SPIKES protocol, which we use, and you should always, when there's a question related to this topic for communication, how you communicate with the patient, you should always write on the paper SPIKES and follow it step by step. So the S here stands for setting. You have to pick a private and comfortable setting. P stands for perception, so you ask them what do you know? What's your understanding of the situation? The I stands for invitation. You ask them how much do you want to know? The K stands for knowledge. You give information in small, clear chunks and you avoid jargon. And the E stands for emotion. You acknowledge and validate their emotional response. So you say this is clearly very difficult news. And the S stands for strategy, summary, and make a plan for what comes next. So on the paper, you should always write SPIKES down and see what the question stem has already said. So they might have a PICTA setting. They might have said, okay, now you are in a private room, so BS is done. Then what's the best next step in management, or what's the best next step to do? What are you going to tell them? So we will go with the P, which is, we say, perception. What's your understanding of the situation? You should always write SPIKES and go with it step by step. For counseling families, the end of life is marked by fear, loneliness, and distress. So you should always listen, provide emotional support, and normalize these feelings. You should utilize psychosocial and spiritual counseling, and remember to offer a referral to a hospital chaplain, social worker, or psychologist.